Welcome to Politics Done Right on KPFT. I am your host, Egberto Willies. This is the progressive program that will take the mystery out of politics. This is the program that will encourage you to make sure government becomes we the people. Whether you are liberal, conservative, or otherwise, you get to air your point of view. Give me a call at 713-526-5738. That is 713-526-KPFT. Remember, you can also send me a tweet to EGBERTOWILLIES. That is at Egberto Willies. Let us engage. It is politics done right.
1, 2, 3, 4.
Okay. All right. Let me do first. All right. Welcome to Politics Done Right. This is Egberto Willies. We are going to have a wonderful show today. I have a very special guest. Who do I have here in the Politics Done Right studios right now but Dr. Anand Bhat? Look, it's a pleasure to have you here.
Thank you for having me, Egberto. It's great to be on KPFT for the first time.
I have a thing with doctors, right? My sister is a doctor. My daughter is going to be a doctor. But my daughter and my sister are both very altruistic people. They believe in really doctoring. And I don't run into a whole lot of those. When I ran into your father, that's what I ran into. And I think that's why the conversation lasted as long as it lasted. Now, when he told me about you, he said, something, but, in as much as he believed a lot of the things that I was saying, he said, but my son is more like you in the way. That's what he said. He said,
yeah, it's just the millennial baby boomer gap.
Right. He said, my son is more like you. And I said, what do you mean? He said, he believes in that Medicaid, the Medicare for all thing too. And I was like, oh, good. And then when he came back in and he said, he had you on the telephone and he said, my son is on the line and he listens to you. And I'm like, great. So we had a talk. So anyhow, welcome to Politics Done Right, my friend.
So great to be here. We met actually for the first time in 2016 in Philadelphia.
Yes, we did.
We were both Bernie Sanders delegates, actually. I was representing Ohio at the time.
And I was representing Texas. He's going to talk about the myths and lies of the healthcare quality industrial complex. Dr. Bhat, why don't you tell me a little bit about the genesis of this document?
Okay, so I left, I'm from Texas, lived in Texas my whole life till about 2012, went to medical school in Galveston, and I'm a Longhorn, like Egberto here, went to University of Texas. I left in 2012, and I was living in Cleveland for a couple of years, and then I was in Kansas City recently, and now I'm in Michigan. But I came across one of my wife's friends that started a new magazine called the Cleveland Review of Books, and in the Cleveland Review of Books, we're going to... he wanted something to do with healthcare because Cleveland is such a epicenter of healthcare, and wanted somebody who had informed opinions about medicine to be published because that's a huge community there with the Cleveland Clinic, Case Western, and all our large hospitals they have in Cleveland. So I told him I could write an article for his first issue, and I said I want to write about something that I don't think anybody's written about, nobody said, and nobody said it quite the way I was going to say it. So I called it The Myths and Lies of the Quality Industrial Complex. So, at this point, I had worked in 3 different states in different settings, in Texas, Kansas, Ohio. I had seen how healthcare sort of works in different types of hospitals. So I practice internal medicine. I'm currently working on and off as a hospitalist. But so the name of the article is called The Myths and Lies of the Healthcare Quality Industrial Complex. So this is something that people may not know who are interested in single payer, Medicare for all. I've been promoting single-payer Medicare for all with Our Revolution, the DSA in Kansas City, and now in Michigan, and just trying to educate the audience about this topic. But I wanted to write something that isn't about that topic because I think people are starting to learn about that, but I think we have other issues that nobody's talking about, but doctors live every day. The main issue I want to talk about was how... Once upon a time, I don't know if you remember, Egberto. Do you remember the article in the New Yorker a few years ago about McAllen, Texas having the most expensive healthcare?
Yes, and that's an example you use. Absolutely. I remember that very well.
Yeah. So when I was in medical school in Galveston, we used to go down to Brownsville and practice in the colonias, which are these areas which have no water, no city services, no roads, no dog catchers even. There's like, rabid dogs running on the streets. And, when Dr. Gawande wrote for the New Yorker that McAllen had the highest healthcare costs, I thought it was a great idea. I went on to study a master's in health policy. And, it was kind of like I learned about something. And then when I was learning it, I realized it wasn't true. So what I feel is a topic we're not when we talk about healthcare coverage, which is important, we're talking about single payer, we're talking about the issues of covering all Americans and having a cost-efficient healthcare system. But what is currently happening under Obamacare, starting with Obamacare, maybe a little bit earlier, is this push for quality measures. So have you heard much about quality measures in the media?
Well, you don't hear about that because it's not sexy.
It's not sexy. So there's an idea that we're going to measure healthcare quality and healthcare outcomes, and we're going to compare them.
Now, President Obama did mention that every time he talked about it, but it's something that was just always glossed over.
Right. So a lot of things that doctors you may meet will be complaining about is the satisfaction scores. That's one very famous one. You may get a satisfaction score from something called HCAHPS from Medicare. And they are rewarding and punishing hospitals based on their satisfaction scores, like this is Best Buy. And I think most people would disagree with this who practice medicine. But I wanted to...
Why would they disagree with it?
They would disagree with this because I think, like, say when I was in Ohio, you had a huge narcotic issue. One of the top, 3 or 4 states for narcotic abuse. And patients would demand narcotics, and physicians were scared to say no because they would get a lower score potentially.
Right.
And the hospital executives who are now running these hospitals, not doctors, they are pressurizing doctors to do whatever it takes to keep the patient satisfied, even though it could kill them or they could become drug addicts.
So this satisfaction score that you're talking about, you're saying that the patient has a whole lot of input into it, not necessarily based on the actual physiological outcomes, but just how they feel.
Yes, how the patient feels. And there are hordes of people being hired in hospitals to maintain patient satisfaction.
Oh.
Yes. So a lot of hospitals now have an office of patient care experience, offices of patient quality, and every quarter they ask doctors, and just like you were working in, say, some sort of sales job, they ask you, well, did you know your satisfaction score was low this year or this quarter? You didn't get enough, even though it's not a majority of patients that fill it out. It's a very small minority. It's actually very few people.
But isn't it true also that a common human experience is that you only complain when something doesn't go right, and when it goes right, you generally kind of, maybe you'll give some kudos, maybe not.
Right. Well, so these surveys are, I think, mailed to your house, but most people don't fill them out.
Right.
I don't know what the percentage is, but it's the vast majority are never filled out. And if it's an elderly parent, it may be filled out by the kids. And the parent may be happy, but the kids may not be for whatever reason. So I wanted to talk really about these quality measures and how it's become, just like you have what is that thing they call the military industrial complex?
Right.
I'm calling this the quality industrial complex. We have these consultants, these computer companies, these survey companies. They are minting money off of these quality measures.
It's almost like it seems like the medical industry, and we'll talk about this another time. There are always these side companies and side organizations that come into the medical field, and generally having nothing to do with medicine. You went ahead and got your education to become a darn good doctor, but somehow some corporation is going to create some external force that comes in and then judges you.
Yes, and actually this is a threat to the practice of medicine because only somebody within the field can judge the quality of that field. So I can't judge, cardiac surgery because I'm not of that field. It takes only a cardiac surgeon to judge that. Just like when you vote for judge, how do you decide who to vote for judge? It's something everyone here in Harris County has to do.
I don't know.
You don't know. Well, you have to look at what the Bar Association tells you or what the police tells you. Nobody thinks an outside quality company doing judge satisfaction scores gives you your rating. You go by what the Houston Chronicle
Right.
tells you. You go by the local bar association, the prosecutor association, people who are in the field judge you. But in medicine, we're being judged by people who aren't in that field.
Right. And that's just a set that these are just companies that came up, public companies that came up to do this job because it was written within the Affordable Care Act.
Yes. And the consequences, I think, are huge. There was an article earlier this year in JAMA which is showing that when you it's not like there isn't poor quality happening. I mean, there is poor quality. There are things that need to be improved.
Right.
But these are complex issues that need to be handled with relationships, very specific doctor-doctor communications, and very, very difficult to fit in some sort of survey.
Right. So, I mean, do you look at this as a big hindrance to the law, or is this something that needs to be mitigated? I know we're going to talk about Medicare for All later on, but right now what we have in America is the Affordable Care Act. So what are I know you explained what are the consequences of all of this?
So here's this consequence from JAMA. When they looked at JAMA is the Journal of the American Medical Association, and they looked at punishing hospitals. If you do well on the surveys, you will get a bonus. If you do badly on the surveys, they will punish you 1 to 2%.
Wow.
So this is why all the CEOs are hassling about these quality measures. Satisfaction is only one of them. I don't want to make it sound like satisfaction is the only one, but that's the main reason why the CEOs and CFOs are hassling doctors about the satisfactions and other quality measures.
Now, what can be done?
Well, what's happening, first we have to describe what's happening, because I don't think people know. Overall, hospitals treating high-income people who are already healthy will win the surveys, and they get the bonuses. Hospitals treating poor people of low income in any region are getting punished overall. So we're having a redistribution of money from those who treat the rich from those who treat the poor. That was in JAMA this year.
No, okay, so they've already done the study of the consequences of these what do we call them, of these
quality measures. Yes.
Quality measures.
Yes. So this was probably warned by many people that overall, if you go with quality and satisfaction, really that's a stand-in for your socioeconomic status, and that places with generally poor quality or poor outcomes are just poorer places, and those that have better are generally richer places.
You know, do you think a lot of times they call these unforeseen consequences or things like that? They actually wanted to do good, but ultimately the results from trying to do good was. Do you think that's the case, or do you think this was planned?
The further I look into this, and I came across a book called Poverty in the Midst of Health Reform, which I discussed in this article in the Cleveland Review of Books. I think it was potentially foreseen. I don't think I knew when I read that article in 2008 or 9 by the Atul Gawande that I didn't understand the genesis of this idea. The genesis of this idea was from Dartmouth University, something called the Dartmouth Atlas. And a lot of those professors have for-profit companies that they've created, which helped write Obamacare.
Yes.
And I think their own accountable care organizations that they've created, if I'm not mistaken, even Dartmouth's own accountable care organization has failed. So the idea was to pay for quality, but I think we're missing the key ingredient, which is poverty. And that's what I get into in this article.
So explain that.
So I studied in London at the University of London School of Economics and the London School of Hygiene and Tropical Medicine. So anywhere you are in the world, the WHO has studied this. There's a book called The Health Gap in the United States, which talks about this as well, or The Spirit Level is another book that's also published in the U.S., but The Health Gap is by Dr. Michael Marmot. And Dr. Michael Marmot is an Australian doctor, and he studied in England for many years that poverty causes more death than anything else. So he looked at government workers at Whitehall, which is a building which has all types of government workers. So in Britain, when they do surveys, when they do, I don't know if it's on the ID card, but they classify people not by their race, but by their class. So there are grade 1 workers, grade 2 workers, grade 3, grade 4, grade 5. So a grade 5 worker, and this is how they do polling. This is how they try to do outreach, not by race, but by your class, your class.
Right.
So he was showing all of these people in this building were working, okay, which already is a good sign for their health. But people who were working unskilled labor jobs had higher rates of hypertension, strokes, and heart attacks than those who were grade 4, then grade 3, then grade 2, and grade 1. And it was a line. It was a straight line.
Perfect correlation.
It was a perfect correlation. And so people had increased mortality, and that mortality went down based on your grade.
But it's interesting that you're finding that in the UK, because the UK medicine for everybody is pretty much the same, right?
That's the fascinating thing. You're exactly right. So if you're at Parliament in Big Ben and you ride a subway east,
right,
life expectancy falls 6 months every stop east, because East London is poorer than West London.
Really?
Yes. Even though the healthcare is free,
right,
even though there are no copays, even though there's no hospital bills, and prescription drug prices are capped for the patient at like $15.
Now, here's my question on that, because I, as an engineer, I always look at the numbers, and my theory would be, and I'm going to give you a theory. Tell me if I'm correct. People know when you go to the hospital, and as much as it's free, do they have an idea what class you fall into?
Oh, so you're thinking maybe discrimination?
Right.
Well, no, that's not the. Well, I think the pathway by which this happens is stress.
Okay.
So the lower, even though an executive may think they have more stress, physiologically, that's not been shown to be true.
Now, the question when you say physiological, there's stress chemicals that the body gives off.
Yeah, the stress hormone.
If you go ahead and test a stress hormone in an executive that is under pressure, and you test the stress hormone in the street sweeper who doesn't know if he can make the next bill, are you telling me that stress is likely to be higher in that person who doesn't know about the next bill?
Yes.
Wow.
Yes. In fact, there was a study in the Journal of American Medical Association that compared only white Americans against the British.
Right.
And they took stress hormone levels, and they divided all white Americans and all British people into thirds. Top 1/3 of income, middle 1/3 of income, and bottom 1/3. And they did same for the British.
Right.
And they took the stress hormones, CRP, and measured them. And as they went up the income of Americans and British, the stress hormones were lower in higher income people than middle income, which were highest. The stress hormones were highest in the lowest income in both countries. But the most fascinating thing was the stress hormones in lower class British were still lower than higher class Americans. And this is white Americans.
You're kidding me.
No, I'm not joking.
What explains that? I don't even know what to say then.
Well, Egberto, you're from another country. Wouldn't you say this is a pretty stressed out country?
Actually, it is a very stressed out country.
Yes. Even rich people in the United States are more stressed out than poor people in Britain.
Well, and you can see that, I mean, in as much as you're rich or whatever, you can still think that there could be something physical that happens to you that wipes you out. In Britain, that can't happen.
Well, it does happen. It just happens to a smaller degree than here.
Yeah.
Yeah. The stress hormones contribute to the blood pressure.
Right.
And, it's complex, but it will, leads to hypertension, which leads to the heart attacks and the strokes, ultimately.
Right.
And that class gradient also explains, and I'm not an expert in this, and I would have to look into it. They think that might explain some of the hypertension risk in the African American population is stress.
Right.
It's not purely physiologic. It could be, and there's differences between, say, African immigrants to the United States and African Americans, because they are less stressed out than the ones who were born here.
Right, and that is understandable, because I try to explain this when I'm talking to folks, when I try to talk to them about you have to adapt to your conditions or whatever. When I walk into a store as a black person, I know I'm followed. When a born black person walk into the store, the way they look at it is, I'm tired of this. This has happened all my life. In my case, I come into here and I sit down and I say, sometimes I actually find it, I'll get mad every so often, but sometimes I find it amusing. So our reaction to these different externalities or sort of
Because you
different-
probably know a place where you are accepted,
right.
and those born here they're not accepted
That's a
potentially
very
in their
good-
own country.
That is a very good point.
Perhaps if they visited, Brazil or Jamaica
Right.
or Africa,
Right.
they would know that there's a place for them too.
Exactly. That may be a good that may be a good point. Well, let's continue.
So
talking
go
a
back to
little
the
bit
articles.
about this.
So
Yeah.
again, so class and health. So what I said that this was a huge problem. So I said, what exactly is wrong with the healthcare system? So I said, what we have here is a healthcare problem which is due to costs. So if you look at any company or any revenue, it is prices times volume. So Walmart sells a lot of stuff cheap, and that's a lot of revenue, whereas maybe Rolls-Royce sells few expensive things. So that explains high revenues.
Right.
The United States, in terms of healthcare units, however you measure it, has high costs overall. But the prices are high and the volumes are actually average. It is not like people are using or going to the doctor more than average in the United States. It is actually average, in many cases, below average of other developed countries.
Really?
Yes. So just to compare to our neighbor Canada, we see the physician less per year than Canadians.
Even though we pay a hell of a lot more.
Yes. The Uwe Reinhardt, I'm not sure if I'm saying this right, he was a Princeton economist, and his article written in 2003 said it's the prices stupid. And he says that is what the United States stands out for. It's not that we go to the doctor or use more prescriptions or stay in the hospital longer. It's the prices that make the United States healthcare the most expensive healthcare system.
Wow.
And this is why we need, single payer. Now, that's obvious. Anybody who, most people know that, okay, because they've paid the bills, okay? Now I'm going to get into the quality thing. Now, how do I make that up? How do I get that back to McAllen? High usage rates. Are there areas with higher usage rates? I said overall, the American usage rates, whether it's days in the hospital, prescription drugs, doctor's visits, is about average for other developed countries. Are there areas with high volumes? And what is shown is those areas tend to be high poverty areas.
Wait. So the people that are poor, and why is that? Because
Because they're sicker.
Oh, okay. What I was wondering is, it's a lot of very poor people get health care for free in America if you're poor enough.
On Medicaid, yes.
On Medicaid. So I was wondering if there's a correlation there, or is it that you're really sick?
So this was not traditionally true, but currently it is true. Poor people use the hospital more than rich people.
Okay.
But poor people are also sicker than rich
Okay,
people, who
okay.
are sicker than middle class people.
Okay,
So
got it.
it goes straight up a line. So also income inequality. States that have lower income inequality have better life expectancies for everybody, for the poor, the middle class, and the rich.
Less income inequality.
Yes.
Okay.
So more
makes
equal
sense.
countries, Japan, Canada's significantly more equal. Even within the U.S., Utah,
Right.
Vermont, those states have better life expectancies. Minnesota's another one too. So that inequality is good for everyone's health.
So New York should be pretty bad.
New York should be very bad. I think the reason New York is okay is because of massive taxing and spending
Right,
on
right.
welfare programs.
Right.
California also very unequal. Texas very unequal. I think New York is more unequal even than Texas. California is more unequal than Texas, but Texas is pretty unequal.
Yeah, but those two states have services. Texas does not.
Yeah, that's true. So now, when Dr. Gawande went to McAllen, he started talking about these volumes, okay? But I think a systematic review looking at all these views done in this book by John Hopkins called Poverty in the Midst of Health Reform by Buzz Cooper showed that one of those areas was his hometown of Milwaukee. And he had grown up in Milwaukee. He was the dean in the Medical College of Milwaukee. So he reviewed the neighborhoods in Milwaukee and tried to find out where was this increased use of healthcare. And he said it was really in this high poverty neighborhood
Yet again.
in Milwaukee. Overall, Wisconsin is a state with educated, higher income people with relatively low inequality by American standards. If you take Milwaukee out of the Wisconsin healthcare spending and outcomes, it's actually the same. If you take Milwaukee City out and you just do the Milwaukee suburbs, there's no difference in usage rates. If he took out the zip codes that were not the high poverty corridor, as he called it, the usage rates in Milwaukee were the same as the rest of Wisconsin. There was no difference between suburban Milwaukee and the rest of Wisconsin, and even the parts of Milwaukee that weren't high poverty.
Wow.
So, again, to get back to quality, we can see the low quality is often going to be linked to the poverty of the neighborhood.
Wow. Wow.
And just to give very simple examples.
And let me stop you right there. The low quality is based on the neighborhood, and these are where sicker people are, and more than likely sicker people, you also have worse outcomes.
So poorer people are sicker.
Right.
Poorer people come to the hospital sicker.
Mm-hmm.
Poorer people will stay in the hospital longer,
Mm-hmm.
and poorer people with the same disease would be more likely to die in the hospital.
Right.
Therefore, anyone measuring the quality would say, why did this patient with a heart attack die, but in Kingwood, he lived?
Right.
Well, they're not the same patient.
Right.
I worked in Cleveland. I've worked in the Cleveland suburbs. I've worked in a town outside of Cleveland, which was a Rust Belt town where they lost all their factories.
Right.
And I can tell you the most noticeable thing with the sickness of the patient was how poor the neighborhood was.
Right.
I, as a doctor, did nothing different. The patients were sicker because the patients had no jobs.
Mm-hmm.
And when you're in the big cities, you may have public spending to help that out.
Mm-hmm.
But some of these towns that are smaller, that have high poverties, those are probably your sickest towns.
Right.
Because they don't have a Bentob.
Right.
They don't have an LBJ.
Mm-hmm.
You know, it's probably places like Galveston, places like Port Arthur in this area that probably have the sickest people, but no public spending to help them out.
Mm-hmm.
So that's what I've seen in my personal experience. I worked in the suburbs of Kansas City. I didn't have a single emergency happen to me. I went back to my old job in Lorain, Ohio,
Mm-hmm.
and we had, every morning there was a medical emergency. You know, it wasn't that I was any smarter or dumber. It was just the
Right.
patients were sicker, and that town had no jobs.
So your personal quality control was a whole lot different in two different hospitals just because of the patients you were seeing.
Absolutely.
Nothing else.
Nothing else. In fact, this is the problem with not having single payer. If you want to rewind this,
Right.
insurance companies are trying to select people who are healthier.
Right.
And if you have multiple insurance companies, people will fight. Whereas if you cover everybody either by geography, everyone in Harris County, everyone in Texas, everyone in the U.S.,
Right.
you can't try to choose the healthy people in the healthy neighborhoods.
Just one pool.
Just one pool.
Yeah.
And that's what we noticed.
Right.
And essentially this is what's happening. And that's why you're seeing overall the quality being shown to be poor at the places treating poor people,
Right.
and they are disproportionately getting the punishments.
That is sad. That is sad. So continue with your article.
Yeah,
because
so we'll
this
go
was an
through-
intriguing one.
Yeah, so I mentioned the Whitehall study, and I mentioned this. The United States, if you look at the towns that have these high expenses, and again, the expenses are not the prices, because the prices are high everywhere. So the only way one city in the U.S. is going to be more expensive than another is the more volume.
Right.
And the more volume is going to be explained by the poverty rates.
Right.
So what are the bad examples? Miami, Los Angeles, New York, Milwaukee,
Chicago?
Chicago probably, yeah.
Yeah.
But those would be the high ones. But what are the cities they cite for being the best? Utah, Grand Teton, Colorado.
Oh, really?
Within Texas, I think the only one is maybe Temple, Texas.
Really?
Yes. Iowa. Okay. And so the author of this book says that, well, if you notice, all of these places cited don't have high poverty rates.
Right.
Los Angeles has more poor people than most cities have people, if you think about it.
That's true, but based on the volume of folks that live in there, yeah.
So, unlike, and when he did the analysis in Los Angeles, he looked at the zip code. He did it by zip codes because poor people live all over Los Angeles.
Right.
I think I saw a report recently. California is actually the poorest state, has the highest poverty rate in America.
Yes, actually, I did see that.
Yeah, it was 20% when you include cost of living.
Right.
It's higher than Mississippi.
Right.
So it's 21%. So he looked at the hospitals that have the highest usage rates were, for example, one near Skid Row, which has, I think, 50,000 homeless people right next to that hospital.
I didn't realize it was that bad.
Yeah, it's that bad. So meanwhile, these areas that they cite, Iowa, these are not models for Los Angeles or Houston or Cleveland or Detroit to copy. Iowa, and I start the article with this, when somebody was from Iowa was saying how he had the best asthma outcomes, and somebody from Atlanta said, guys, you're in Iowa, I'm in Atlanta. It's completely different here. And what's the difference? Obviously, poverty, race, health insurance, a state that probably has very low welfare spending. Stress.
Yeah.
We can't compare these. And when Atul Gawande went and cited Mayo Clinic, Minnesota, these are not the places that you can replicate in places like Houston and Dallas.
Right.
So no, if you're asking me, is this a good project went wrong? I think if you really dig into it, maybe it was not a good project that went wrong. Maybe
it was a bad project.
It was a broad project that went right.
Exactly.
Because there's no way we were going to turn Atlanta into Iowa.
Yes.
So now, this brings me to the end of the article, which is, well, in most countries, or any developed country, does price controls on the doctor's visits, hospital visits, pharmacy visits. Okay, so in Obamacare, we didn't do any of that. Okay, we did no price controls.
They couldn't, and get it passed.
We'll why we won't discuss, but it's not like these Dartmouth or Atul Gawande, these Boston people were not interested in that.
Exactly.
They were interested in what I call a volume control strategy.
Right.
And how do you control volume? Okay? Because in Britain, and we were talking about waiting lists, in countries with universal health care, they do and can have waiting lists to control the volume so they decrease the spending. Because X number of cataracts per year, X number of knees, this happens. So what we have is a system that won't do price controls, but is inadvertently is doing a form of volume control. And you know why that's dangerous in this country?
Explain.
Volume control, because the high volumes are associated with high poverty, volume control will lead to the death of poor people.
It's an implicit genocide.
So now you may think I'm being hysterical here and saying, well, they're trying to do volume control. Well, there's a couple ways you can do volume control. Okay, practically what happened? Mergers, mega mergers. My old company in Ohio just got bought out by a company in Austin.
Wow. A
large primary care group in my hometown of Beaumont got bought out by a company in Boston. We're having mega mergers on a national scale. Within the Houston area, I've been out for a couple of years. I've heard Memorial Hermann is expanding. In Ohio, the Cleveland Clinic is expanding. University Hospitals is expanding. They're buying up physicians' practices left and right.
Yes.
Now, in the 90s, it used to be that the insurance companies were the bad guys. But what we're going to see here, and what has been seen in Boston, which again has had Romney Care before anyone else. Yes. Massachusetts General and these big Harvard hospitals bought out all these practices.
Right.
And they charge double what the practices used to charge. And the same thing is happening with the Cleveland.
But that is opposite. You're saying it's volume control, but right now you're talking about increasing price. Are you saying controlling volume based on price, or? Well,
it's a little complex. What I'm trying to say is a normal healthcare system would have a referral system. Like take the VA. Okay, I'm from Beaumont. The VA in Houston is the headquarters for this region.
Right.
So if you need something special in Beaumont at the VA, you need to come to Houston.
Right.
Okay, but we don't have that planning.
Right.
So instead, the big hospitals in the downtowns are sort of creating their own health services by buying out in the suburbs and rural areas and using a for-profit, not a proper healthcare referral network, but a for-profit referral network back into the downtowns.
Right.
Okay. Now what's happening is the hospitals are becoming so big, they are bullying the insurance companies to charge more.
And deny more in the process. Huh?
Yes. And they're creating their own insurance companies. Okay. In Pittsburgh, the University of Pittsburgh Medical Center created their own insurance product.
Wow.
And the hospitals are buying out the doctors. So the same doctor Same cardiologist, his office visit becomes a hospital visit. He hasn't moved, and his prices have gone up astronomically.
Because now it's a hospital visit.
Now it's considered it's something like that. It's considered a hospital coded visit. So the same echocardiogram and stress test, which was considered an office visit, it will now be considered a hospital facility.
That is by design. They purposely left that in. One of the things that I wrote early on during the Obamacare debate was Obamacare was a good first step to single payer for a company that was anathema to single payer. It was a good way, and especially if it had the public option, because what it was going to do is eventually converge to the public option. But what you're telling me here is something that I don't think a lot of people realize. Given that these are the folks who wrote Obamacare, they made sure to write those hooks in there that this could be realized.
Yes, because, and what I'm saying is not controversial. Have you heard of that movie Spotlight?
No, I haven't.
The one about the child, the Catholic Church it won the Academy Award a few years ago. You maybe heard. Well, Spotlight is the Boston Globe newspaper.
Right.
And they won the Academy Award for the article about the child abuse in the Catholic Church.
Oh, yes. Okay.
Okay. So everyone look up Spotlight Boston Globe. Look up Partners Healthcare. And Partners Healthcare is what Massachusetts General and Brigham and Women's Hospital is. So before or after they exposed the Catholic Church, they do one big expose a year. They exposed how these merged hospitals were increasing prices all throughout Massachusetts.
Wow.
And that was a Boston Globe investigation. So I'm not even saying this was going to happen, because Massachusetts was the forerunner of the nation.
Right.
And so when I say they're doing a volume control, this is what's happening, is they're controlling the volume by controlling all the referral areas around the big cities. Okay. Now, another reason why I think this is extremely deadly, there was one program called, the narcotic epidemic I told you about.
Right.
The satisfaction scores probably have scared doctors to writing narcotics.
Even
probably responded. That alone probably has killed thousands of people.
Right.
Thousands of people just based on that. But here's one you may not have heard of: the heart failure readmissions reduction program. When I was in Cleveland, which is a great city for cardiology, I talked to a heart failure professor. The government was punishing people who were readmitted to the hospital within 30 days, who had heart failure.
Really?
Yes. So they were noticing that I can't remember the number, 15 or 20% of people got readmitted to the hospital who had heart failure. So they said, we want all hospitals to reduce that, or we're going to punish you.
And what did they do?
Well, they started hiring all these quality staff to reduce the readmissions in the heart failure, getting them, follow-up appointments quicker. I mean, some of it's good. There's no doubt about that. But what the study showed in the Journal of the American Medical Association, they showed that heart failure patients who were not being readmitted were actually staying at home and dying.
Oh.
So the readmission rate for 30 days had fallen. And I asked the professor this. I said, can you predict who will be readmitted to the hospital within 30 days? He says, there is no way to predict.
Right.
If I had to guess, probably poverty, lack of access to a car. This is in Cleveland.
Right.
But he said, we can't predict it. We can't do anything. There's no medication we can give. And I said, what if they had a medication that killed you on day 29 and you didn't come back to the hospital on day 30? Wouldn't your score go up? And
Yes.
he said, yeah. And he said, yes.
Yes.
Well, I was right. And I was a second or third year resident at this time.
Right.
And I was right. People were, the 1 or 2, they cut it by 1 or 2%. I think it went from 18 to 16%, the readmissions. But that 1 or 2% of people were
Cost a
dying
lot
at
of lives.
home.
Yes,
So 5 to 10,000 people died because of this program, where we did not have evidence for this quality measure. And that quality measure has killed, they estimate, 5 to 10,000 people over 8 years.
Sadly, when I tell people a lot of times, and you hear my program sometimes, they think I'm hyperbolic, but I think this is so immoral. The things that we are doing, I mean, an economy, insurance, and all of these things are supposed to work for people. People shouldn't have to be tailored to fit these man-made programs. And I think that is what's happening in this country and probably in other places as well. We are tailoring structures. I mean, we're tailoring humans to structures instead of structures that fit the human condition.
I think that's one of the purest statement of neoliberalism is that we, instead of having an economy for the people, we fit the people into the economy.
Exactly. I mean, I find it amazing to have a doctor talking about neoliberalism. I mean, I honestly find it amazing. So conclude this paper before we go into Medicare for All.
Sure.
I want to hear what you want done. And this has to be in the short term because our goal is really to institute Medicare for All within the next 5 years.
Yeah, I agree. So I'll just read the concluding paragraph. The myth that so this is the myth that everyone was talking about, that 1/3 of healthcare spending in America is wasted. So this is how I concluded the article. The myth that 1/3 of healthcare spending is wasted due to unnecessary usage as opposed to high prices, high administration costs, and high poverty rates in the United States is probably just that, a political myth. The Dartmouth, Orzag, Gawande gang have committed malpractice by perpetuating this fable across the political media. It is a fable popular in Washington, eager to justify spending cuts, attacks on physicians' clinical autonomy, and ignoring the real work of bringing hospitals, insurers, and pharmaceutical companies to heel.
Excellent way to close it. Now, my question to you is, Medicare for All mitigates it all, don't it?
Well, no. I think we need to talk about implements. Yeah.
Yeah.
So what I wanted to show was, I'll give you a Texas versus Ohio example.
Let's go.
I'll give you one. Okay. So when I grew up, and went to college in the sort of George W. Bush era,
Right.
and then I moved to Cleveland in 2012, and I joked that the bad guys in Texas, they look like bad guys.
Right.
You got Dick Cheney, you got Rick Perry, you have who's the lieutenant governor?
Patrick.
I mean, you can't, if you have a conscience, look at these people and say, "Oh no, he might be right." No, if you have any self-insight, the bad guys, they look like the bad guys.
Yes.
What I think you have up north is it's 90% of the same,
Right.
but they went to Harvard.
Right.
We're nonprofit.
Right.
We're the Cleveland Clinic.
Right.
We're Goldman Sachs.
Right.
We're here to help you.
Right.
The bad guys don't look like bad guys.
Oh, you know what is so interesting? You've heard some of the shows where I've, when we've talked about how things are in the South and people talk about all the isms that occur in the South. And I tell them, we need to stop that because we have to remember that the busing riots didn't occur in Jackson, Mississippi. It occurred in Boston,
Yes.
Massachusetts. You know that?
Yeah.
So, I mean, there are things like that people don't grasp. And I'm glad that you actually brought that up.
Well, yeah, because I think the looting, these big nonprofit hospitals in the north, they're just as bad as, ExxonMobil or the
Right.
Wall Street companies in New York. They're just as bad
Right.
as any of these oil companies we have here in Houston.
Right.
But at least at the end of the day, the oil company put gas in my car. Goldman Sachs didn't give me a tax. Didn't give me anything.
I am. Look, that is where we get a generational change. There is a loving, there is a reverence that we have a tendency to put to these the titans of capital that I think is undeserved. And I like what you just said. At least Exxon gives you a value for when the other guys give you a thought. A maybe.
Yeah.
Maybe today you'll have this piece of paper would be worth something. Maybe tomorrow it won't.
Yeah, yeah. So Medicare for All, I'm for it.
Mm-hmm.
I've been supporting it since at least 2007, since I was in medical school.
Now, let me ask you something. You are around doctors of all ages, of all classes, etc. Where do you? I worked with the the national, what is it? The group of doctors that want the national health care.
The Physicians for National Health Plan.
Physicians for National Health Care. Love those guys. Where do you feel the center of gravity is on Medicare for All for doctors at this point?
Probably higher than it's been.
Uh-huh.
I think surveys, maybe even 10 years ago, were showing a majority were supporting it, which is a big contrast to before 2000. But if I'm not mistaken, majority have supported either universal health care.
Mm-hmm.
I'm not sure if single payer, but at least for 10 years.
Interestingly, single payer would alleviate for all those doctors that have private practices. It'll get rid of most of their employees, right?
Well, yeah, actually, yeah, it would. The thing that also is interesting is the specialty.
Right.
Certain specialties are very anti Medicare for all.
Of course they are.
You'll see great support in, say, pediatrics,
Right.
but you won't see it in, say, orthopedic surgery.
See, that's what my sister is in pediatrics, and she wants that. Now, interestingly, in England, I can even the way they implemented it. I think in England you have one doctor that sees somebody through their entire. He has to give a referral, everything.
So Medicare for all. If you want to talk internationally, we need to only talk about a few countries: Canada, Taiwan, and South Korea, and maybe Australia. Britain is not on a Medicare for all program.
Okay, explain.
Britain is like a large VA.
Mm-hmm.
Basically, everybody goes to the doctor in their neighborhood.
Mm-hmm.
You can't choose your general practitioner.
Right.
And the government owns all the hospitals.
Okay.
And your doctor will refer you to any specialist that you need. You can't go by yourself.
Mm-hmm.
And it's like a big VA.
Right. Okay.
There's no insurance. There's no
Right.
bills. So like
Right.
in Canada, the government pays your bill. In Britain, there are no bills because everybody's on salary.
Right. Okay. Gotcha.
It's like asking me, well, how much does it cost to borrow a book from the library?
Mm-hmm.
You don't know. It's a library service.
Now, how is the quality of care in England compared to, let's say, the quality of care in these other countries that you would prefer us to mimic?
So the quality of care is that's interesting. So if you want to compare developed countries, you need to look at something called the Commonwealth Fund.
Mm-hmm.
And they've compared 10 to 15 different developed countries. England, in terms of quality of care, is usually one of the best.
Okay, one of the best
Yeah.
with a completely government-controlled healthcare system.
Yes.
Compared to Canada, where do you
Even compared to Canada.
even better than Canada?
Yeah. Canada actually...
Because it doesn't support medicine, I don't think.
Canada, again, I've not looked into the data that closely, but if you look on the rankings, Canada, its main advantage is only in terms of cost control because they
Right.
have Medicare. But in terms of their quality, it's I wouldn't consider it a leader. I would
Okay.
consider other countries to be a leader in terms of quality.
Well, you just mentioned explain. You just mentioned Taiwan. Taiwan, which was, I think, they brought in some university.
From Harvard,
Right.
William, I can't know how to say his name, Shao, I think,
Right.
TSI.
Right.
Oh yeah, yeah.
Tell me a little bit about it. How does it differ from? Why did you use those 4 countries?
Well, those countries have a government health insurance.
Uh huh.
The doctors, the clinics, the hospitals, they may be private.
Mm-hmm.
And so the difference is everybody's on Medicare and you bill Medicare.
Okay, so you go to the doctor of your choice.
Yeah.
And then you bill Medicare for that doctor of your choice.
Yes. That is what a single payer is.
All right.
That is not what Britain has.
Right. And now those countries, how are those countries' outcomes relative to Great Britain? Or to the UK?
I don't think they include Taiwan or South Korea
Okay.
in the Commonwealth Fund ranking.
Okay.
I think Australia is it has pretty good results.
Mm-hmm.
I'm not exactly clear. I've tried to read quite a bit about Australia lately,
Mm-hmm.
but I still don't understand what their system is.
Well, they were attempting to revert again back to a partially privatized system. I think that I don't know where they are in.
Yeah,
that.
it's very confusing because Australia in the 70s and 80s kept starting single payer and then canceling it and then it's very confusing. So I'm not exactly sure how I would typify it, but I think Australia, I'm not sure if it's on the British model or the Canadian model.
But you think the transition as a single payer Medicare for all, the transition toward, for us, is probably best done with keeping doctors private and having a single payer. Then how do you control costs?
Well, first, price control.
Right.
First, price control. I think that's the first advantage we're going to have with single payer is reduced administration. Reduced administration. Here's an interesting statistic I got from the Physicians for National Health Plan. For every hospital bed in the United States, there is one hospital biller.
What?
There is one person working in billing per one hospital bed in the country. That's how many people are working in administration in hospitals. That's just hospitals. That's not including offices.
That is sick.
Yes, this is what I learned at the Physicians for National Health Plan in Missouri.
That makes no sense.
Right. So we're talking about if you implement Medicare for all, and it's included in many of the proposals, you can give them a 2 or 3 year salary guarantee
Right.
with the savings. They won't have to work for 2 years. With the savings, you could give them 2 or 3 years worth of salary to find a new job, go to school, whatever. That's how much money you would save.
If I'm not mistaken, HR 676 take that into account, right?
I think they do. I think
Yeah.
I think it does. The Physicians for National Health Plan program, which is the HR 676, has salary guarantee for the tens of thousands of
That will
people
get displaced.
who will get displaced. Now the question will become, where should we get those people to do different kinds of healthcare work instead of healthcare denying work? Now we talked about poverty and healthcare rates.
Right.
Could we redirect the savings and those people to fixing water systems in South Texas? Could we have them getting healthy meals to older people?
Right. Right.
Are they going to be doing something about child poverty?
Right.
That would reduce it. Where or how or should we redistribute that care?
Right.
Another one, which not so much an issue in Texas, but I think when I was in Kansas is very striking. There are some states that are very large that really don't have any major cities. A question which I have no answer for, but it will need to be part of the conversation. How do we get doctors to those areas?
How, would you go? You're a doctor.
Well, I know I'm not going to go to Western Kansas, but we need to talk about.
What would get you to Western Kansas?
I don't think you couldn't get me to Western Kansas.
So.
But we need to talk about, do we need to have a redistribution of doctors out of Houston and into the rest of southeast and southern Texas? I think that do we have enough doctors in the right areas of Texas?
Right.
I think we need to somehow talk about that. These are the quality things we need to talk about.
Right.
This is real quality. And again, Canada is similar to the U.S. It's very big.
Right.
I think it's not like England or Japan.
That's small and
yeah,
people live in
small.
concentrated
Yeah,
areas.
I think in that regard, the United States needs to learn from a lot of countries. I think probably you would need to recruit from these areas
Right.
and integrate these people back.
Right.
I think one thing you have right now in Kansas or other states that haven't expanded Medicaid, you have we forget rural people have the highest poverty rate.
Right.
Not
right.
the inner city. The highest poverty rates are actually rural areas.
In fact, if rural people know their condition relative to the rest of the country and the reasons why, they sure would stop voting against their own interest.
So we need to talk about getting doctors to rural areas. We need to talk about addressing rural poverty. Maybe we would start saying, you know what would save money? What if in spending $1 million on healthcare, we spent $1 million on a jobs program?
Right.
Okay, maybe per dollar spent is a jobs program for $1 million going to improve people's health more,
Which means less healthcare costs.
which means less healthcare costs.
Yeah.
So dollar for dollar, then you can start talking about what they're talking about in Britain, the
Right.
social gradient, the social determinants of health,
Right.
unemployment, child poverty rates. And remember, here's another interesting statistic, Alberto, you may not know. Actually, nobody knows this
Okay.
statistic. Okay. Everybody knows the United States has very low life expectancy
Yes, relative
compared
to the
to other
OECD,
developed countries,
yeah.
even compared to Central America.
Really?
Yeah, I think maternal mortality rates in Missouri are equal to Belize.
Oh my God. Yeah.
Yeah, so we're doing very poorly here. But do you know when you reach 65, what are the two things that happen when you hit 65?
Medicare,
What's the other one?
Social Security.
Now, elderly people are the only two people who have guaranteed insurance and pretty much guaranteed money.
Money, yeah.
Life expectancy for old people in the United States is the highest in the world.
Because of that.
Probably.
Amazing. Because
But nobody knows this. Nobody knows this. It is in one government document in the National Academy of Medicine, and a physician from Physicians for National Health Plan showed this in a slide. I emailed him because I didn't believe him.
Right.
And he showed from 0 to 10 America, and they compared 15 countries.
Right.
The United States was at the bottom. Age 10 to 20, it's at the bottom. 20 to 30, 30 to 40, 40 to 50. We're at the bottom compared to all the other 15 countries. Then when you get after 65, 70 to 80, 80 to 90, the United States is number one, has the highest life expectancies for people in the 70s, 80s.
It tells you, first of all, that Medicare for all would work.
Yes. And it's an absolutely amazing stat on one chart.
Yeah, come on into
And
yeah.
And I didn't even know this. I had studied healthcare.
You know that believe it or not, that's an important stat because that tells us a lot.
It tells you that we can have high quality and high life expectancy
Absolutely.
if we extend this to the rest of the population.
Absolutely.
And I think the other thing is we need to do something about child poverty.
Absolutely. Look, Dr. Anand, we needed to speak about Medicare for all and a few other topics. But you know what? The good thing about it is now that we've connected on these issues, and now that we found yet another doctor that believes in what he went to school for, believed in supporting folks, believed in supporting humanity for a change in a society that many times is based on all the wrong things. It was a pleasure meeting you. It was my honor to have you here, Dr.
Nice to be here.
And I tell you what, we will do this again. Since you're in Ohio now, right?
Right now I'm in Michigan. Yeah.
Since you're in Michigan,
working in Ohio, living in Michigan.
Right.
Yeah.
What we'll do is sometimes we'll bring you over the video feed and have you bring some of your wisdom over here. You have wisdom beyond your years. So thank you so kindly for having been here, folks. That is Dr. Anand Bhat, and we will have him again in the very near future discussing Medicare for all and many other subjects as relates to your health care. My name is Egberto Willies. This is Politics Done Right, and you know how I end this, baby. I am out.
Thank you very much for listening to Politics Done Right. I am your host, Egberto Willies. You can personally reach me by sending an email to egberto@politicsdoneright.com. Remember, Egberto is spelled EGBERTO. Change starts with you. 90.1 KPFT gives you information not tainted by corporate interest. Please visit kpft.org and contribute. Let's ensure continued access to real information and news remain available to all. Again, thank you very much for listening to Politics Done Right.